dominant inheritance is referring to everything besides the sex that we are. So, you know, all of our other traits besides whether we're a boy or a girl is autosomal. So there's autosomal dominant, autosomal recessive. There's certain inheritance patterns that are linked specifically to the X chromosome. And the Lion hypothesis kind of supported that and how that worked with her theory. Genetic heterogeneity, molecular chromosomal abnormalities. These are things we're going to talk about when we're referring to the patterns of inheritance. Did I skip one? Yes. Hold on. There we go. Autosomal dominant is just what we were talking about. If you have two B's, big B's, capital B's, those would be transmitted vertically from one generation to the next. So the dominant will affect vertically from one generation to the next generation, and it's transmitted that way. So males and females in this particular case are affected equally. If a person carries that gene for this condition, their offspring have a 50% chance of exhibiting the condition. And I don't know if you guys have ever done Punnett squares where you create kind of a graph and you put your two big B's on one side, and then you can select, like if your spouse is big B little b or little b, you put them on the opposite side of your graph, and then you can kind of figure out from there when you bring them together what your chances are of having a child with dark brown eyes or blue eyes or whatever. So if you are autosomal dominant, you have a 50% chance of exhibiting the condition, and for your offspring to exhibit the condition. Okay, so let's talk about penetrance. Penetrance refers to the number of individuals in a given area that are affected by that gene. Some individuals will carry the gene without showing any clinical manifestation of that dominant gene. That would be a lack of penetrance. So when we talk about that, it's how many people exhibit that particular trait. Expressivity is the degree to which an individual is affected. Depending on what we're talking about, you know, it could be someone is affected more drastically than another person. So that's expressivity. How much of that gene is expressed in your physical appearance? Okay, so autosomal recessive then is an individual that exhibits a trait, but they must be homozygous to exhibit that particular recessive trait. So they have to have two little b's to exhibit the trait, because if there's a big B there with a little b, the big B is going to beat the little b because he's dominant. So if both parents are homozygous for a recessive trait, they would both be affected. So all of their children would be affected. So if I have blue eyes and my husband has blue eyes, our kids are going to have blue eyes because we've all got little b's. If both parents are carriers of a recessive trait, say I have a big B, little b, my husband has a big B, little b, 25, if you did that cross, that Punnett square where you line them up and figure it out, you would, 25% of our offspring would be affected. 25 of our offspring would be like us, normal, homozygous for the trait, and 50% of their offspring would be heterozygous for the trait. So recessive requires two of those genes to exhibit the trait. It must be homozygous to show that trait. Consanguinity, I have a hard time saying that word. This is what occurs, or what they refer, or what they call a familial relationship. So generally this describes when families mated or married between close relatives. And the closer you are to that relative, the greater the risk. So there's, as you guys probably know, if, you know, brother and sister, which is a horrible thing to even think about right now, but if a brother and sister were to mate and have children, there's a really good chance of some genetic problems there, because the closer you are, the greater the risk. Okay. X-linked inheritance. So this is going to be on the X chromosome. As we know, women have two X chromosomes, so we can be heterozygous or homozygous for a gene located on that chromosome. A mom who is a carrier, if I carry an X-linked recessive trait, I have a 50% chance of affecting my son and a 50% chance of having a carrier daughter, because son's going to get X from me and Y from dad. I don't carry any Ys. I have two X's. So he's definitely going to get an X from me. And if he's a boy, he's got a Y from dad. So there would be a 50% chance of my son having this trait, this recessive trait. And then my daughter has a 50% chance of carrying that same trait because I give her an X and dad gives her an X. Men have one X and one Y. So on that X chromosome, if there is a deleterious gene on that X chromosome in a male, he is going to transmit that condition or that trait to all of his daughters, because in order for us to have a girl, we donate an X. Men have to donate their X. So if they have a condition that is linked to their X, they're giving it to all of their daughters. I think that's kind of confusing sometimes for people. Are you guys able to hear me still? Because my computer's kind of spinning here, and I want to make sure. Okay. All right, so genetic heterogeneity is a condition that has more than one inheritance pattern. So it'll exhibit differences in the degree of clinical manifestations for each inherited variety. So one generation might show a really strong expressivity, and another one may not show as much. Amelogenesis imperfecta, dentinogenesis imperfecta, those are all inherited oral or dental conditions that we see. And that is an example of how it might be mom had it and now daughter has it, and it's not as bad in daughter, or vice versa. So that's the differences in degrees of clinical manifestations that we're talking about. A recessive, like I said, that person, in order to exhibit a recessive trait, they have to be homozygous for that trait to be seen. So I have to have two little B's in order to be blue-eyed. A single gene is when characteristics or traits are inherited by one, and that's going to be a dominant. Then there's an oligogenic inheritance, which are traits that are inherited by the participation of several genes that are play a role in that. So those are the different types of heterogeneity that we can see. And then there's always multifactorial inheritance patterns. So more than one genetic factor can be involved, like we were just talking about. Environmental factors also participate in the cause of a condition. So there's other things that play into that. But just from this, what I want you to understand is that there's a dominant and there's a recessive. And one of the things that I've seen hit on boards, and I know that I ask about, is if a man has some sort of genetic issue, he will pass that, and it's on his X chromosome, he carries it, he'll pass that to all of his daughters, but he could never pass that to his son because he doesn't donate any of the X to his son. He gives us the Y. So some of the disorders we're going to talk about here are listed. I won't go through them all. You can look through that. We're going to talk about them each individually. Cyclic neutropenia is an autosomal dominant condition. And what this is a decrease in the number of this person's neutrophils. They might also refer to it like neutropenia. You might just hear that. But the cyclic means that there are times throughout a month, let's say, that they do not exhibit this condition. Now, if you guys remember, the neutrophils are the first responder to infection in our body. So if I am a cyclic neutropenia patient, I don't want to be scaled and root planed during my episode of neutropenia because my body is not going to have those neutrophils to respond and help with healing. So this cycle usually occurs every 21 to 27 days. It's kind of like a period. The episodes of neutropenia will last for 2 to 3 days. And during that time, they may exhibit systemic symptoms such as fever, malaise, sore throat, and occasional skin infections as well, or cutaneous infections. If a patient exhibits cyclic neutropenia, not on a cycle, they have neutropenia chronic, that's referred to as Kostman syndrome. And these people we would have to be very, very careful with. With them, they would have to be in consult with their doctor. And if they're chronically affected with neutropenia, I don't even know how large of a window you would have to work with them. So with cyclic neutropenia, those people would normally know they have it. They know when their down days are, when their neutrophils are low, and we would want to treat them when we were past that episode. Okay, Papillon-Lefevre syndrome is a recessive. I'm not going to ask you guys to know recessive or dominant on the test, just so you know. I've highlighted in red the things that I think are the most important, but Papillon-Lefevre syndrome is the peripheral neutrophils are depressed. So you remember how the neutrophils are the first responder and they get into their little taxis and they head out to the site of infection. We don't have enough of those to fill up our taxis to get out there. So it's depressed and we don't have as much help with that inflammation. So in this case, you'll see hyperkeratosis of the palms and of the soles of the feet. One thing for us, I think, that's just horrible to even think about. At 1.5 or 2 years of age, a gingival periodontal inflammatory process develops in these children. The alveolar bone can resorb. We see bleeding and inflammation, mobility of teeth, and they end up losing their primary dentition and their permanent dentition both. All of their permanent teeth are usually gone by the age of 14. And then after, like when they lose all of their primary teeth, their gingiva goes back to looking normal and healthy. And then at 14, when all of their permanent teeth are gone, their gingiva resumes normal, healthy appearance again. This is a pano of a kid with this condition. You can see how all the primary were gone. We see a few maybe lingering, but there's permanent are trying to erupt, but they're gone before they're even fully erupted. And then this is another, this is focal palmoplantar and gingival hyperkeratosis. This one is a dominant condition. There's hyperkeratosis of the palms and hands, of the palms of the hands and soles of the feet with this one too, but rather than the tooth loss that we saw in the the last one, in this one, we see hyperkeratinization. You can kind of see that border all the way around the gum tissue on this person. And you would try to wipe that off and it won't wipe off. You might think Candida. It's not. It's like keratinized tissue all around the teeth, and you're going to see it throughout the mouth. Gingival fibromatosis is, you can look at this tissue and it just looks fibrotic. It looks tough, and it is a component of several inherited syndromes. We see gingival hypertrophy that can cover the teeth sometimes in this, and it's pale. Fibrotic tissue tends to be kind of pale and firm, and it's got sometimes kind of a corrugated looking surface. So our care can reduce the risk of a secondary inflammation and infection from this condition. A lot of times I found with people that had fibrotic tissue too, I didn't see the bleeding that I would see in inflamed tissue normally. It's just really hard, firm. It's just weird. And then there's gingival fibromatosis with isolated areas of this, or it could be a component of another syndrome. For instance, Laban syndrome is one it can be associated with. It can be associated with hypertrichosis. Hypertrichosis is an excess of hair growth. And then gingival fibromatosis with multiple hyaline fibromas is where they have these little fibrotic lesions. And we see that on the nose, chin, neck, back, fingers, and thighs. And this is a dominant condition as well. So these are some syndromes that have been associated with gingival fibromatosis. We're going to talk about disorders of the jawbone and facies, the oral mucosa, and teeth. Quite a few of them here. So cherubism is the first one, and I don't know if you guys, Cupid on Valentine's Day, the chubby little guy in the diaper with the arrow, he's a cherub. So, and he's got kind of a full face, and so that's why this condition got the name. It is a autosomal dominant condition, and we see it more in males. It has a variable expressivity, meaning that some people have this condition, but it's not as severe. It causes a progressive bilateral facial swelling around the age of 1.5 to 4 years old is when it begins, and then it goes until puberty. At puberty, once these patients hit puberty, it stops. We notice ocular, which is eyes, hypertelorism, which means wide set. So their eyes are far apart. And we always see this. This is always present with these patients. There's involvement of the mandible is most common. And if you were to take an x-ray or like a pano, and I'll show you one here in just a second, with the soap bubbles, it looks like lots of little soap bubbles in the image. And microscopically, the lesions resemble a central giant cell granuloma. And this is what it looks like on x-ray. You can see all of the bubbles that you see in the mandible. The size of the jaw tends to increase rapidly until puberty and then remain stable. And I don't know if you guys, I'm sure you guys are familiar with Jay Leno. He's got like a huge chin. I always think of that when I see these pictures. I don't know that he ever had this, but I always think of that because these people have a super prominent chin. After about 20 or 30 years of age, radiographs will show an almost normal bone appearance. So it goes back. So many times after patients hit puberty and reach around that 20 to 30 years of age, maybe even a little before, they could go in and do plastic surgery to kind of reconstruct that and help them to have a more normal appearance. This is a person with cherubism. You can see the eyes, the huge chin. So it can be, for severe cases, it can be quite disfiguring. The next condition we're going to talk about is Ellis Van Creveld syndrome. It's also called chondroectodermal dysplasia, but you're going to hear Ellis Van Creveld the most. It is characterized, the patients exhibit dwarfism, so they're small. You often will see extra digits on their hands, which is also called polydactyly. And it's on the ulnar side, which is the little finger side of your hand. We see hypoplastic, deformed fingernails and toes, curvature of their legs and feet. Some can be handicapped, and 50% of these patients have congenital heart defects. Here's a little baby that has this condition. And one of the things we see orally is the fusion of the anterior maxillary gingiva to the lip from canine to canine. That's something I should have that highlighted in red. You want to remember that because that's associated with Ellis Van Creveld often. The anterior maxillary vestibular sulcus is gone. We often see missing central incisors that can be replaced when their teeth come in with one centrally located abnormal tooth. The teeth typically have kind of a conical shape and exhibit enamel hypoplasia. And 50% of these babies are born with natal teeth. So that means they're born with teeth. So that's another thing that we might see with this condition. Cleidocranial dysplasia is an autosomal dominant condition. In this person, the fontanelles, or the soft spots on the skull, remain open. And so because of that, the cranium will develop into kind of a mushroom shape. It makes the face appear small. The neck is long and narrow. We'll see oftentimes hypoplastic clavicles. So your shoulder bones right here are very small, and they're able to like bring their shoulders around and touch their shoulders. They're able to approximate their shoulders due to the deformation of their clavicles. The premaxilla is generally underdeveloped, so they have pseudoprognathism because the jaw is so small, and they have many, many supernumerary teeth. This is something to definitely remember. They're very crowded in the jaw, and remember, unerupted teeth can develop dentigerous or follicular cysts. So many times they'll go in and remove these cysts to help with the prevention of those developing into something concerning. About 1% of cleidocranial dysplastic patients have cleft lip, cleft palate, or possibly both. And this is an image of supernumerary teeth that you might find in a cleidocranial patient. You can see here the shoulders are able to approximate to one another. Gardner syndrome is a familial colorectal polyposis. So what that means is these patients are known to develop intestinal polyps that can become malignant around the age of 30. So if we have a patient and we see we take a pano and we see osteomas all over in that pano. An osteoma is just a bony lesion in the skull or the jaw or wherever you see it. These can obliterate the sinuses and cause facial asymmetry, and multiple odontomas can occur down in the jaw bones, which is going to be made up of tooth bone. And teeth can exhibit hypercementosis and fail to erupt, so it's like they're ankylosed by cementum. But the important thing is, if we have a patient that has this, we take an x-ray and we find these, your doctor should refer them for further investigation, because intestinal polyps that become malignant after the age of 30 happens often with these patients. So we could possibly diagnose them and catch them in a phase or at a stage where we could prevent that, or at least have a head up on it. If you look at this image, we see lots of odontomas. You can see a lot of those areas down there that look like teeth. And then the osteomas, everything just looks very radiopaque and like there's just extra bone everywhere. So that's kind of what you would be looking for. Mandibulofacial dysostosis is called Treacher-Collins syndrome. And this is characterized by a downward sloping of the fissures, hypoplastic nose, hypoplastic malar bones, and absence of the zygomatic process. So their face looks really small and kind of sunken in. They may have abnormal misplaced ears, a receding chin, and their mouth appears fish-like, and it has kind of a downward slope out at the corners. And many times these patients are deaf due to a lack of their inner ear muscles, or otic, or not muscles, bones, inner ear bones, or otic ossicles. And this is a gentleman that exhibits this, and this little boy he's holding also does. Because of their smaller structure, their teeth are often crowded or malposed. They have malocclusion, oftentimes an open bite with a very small mandible because they have that receding chin. The palate is high with clefting in about 30% of these patients, and due to all of these oral findings, gingival disease is very common with them. Nevoid basal cell carcinoma. We talked about the odontogenic keratocyst, the OKC. OKC is associated with nevoid basal cell carcinoma. This is also known as Gorlin syndrome. And in these people, they have the ocular hypertelorism we talked about with cherubism. This, in this condition, is not as severe. We might see mild prognathism, frontal parietal enlargement of kind of the forehead area, a broad nasal root, so the top part, kind of where the bridge of your nose is, appears broad. There will be cutaneous nevi that are typically basal cell carcinomas. So those are just pigmented lesions in the skin is basically what they're saying there. And cysts can develop as early as 5 to 6 years of age, which can interfere with the development of their jawbones and teeth. So this is nevoid basal cell carcinoma. Here is an image that's showing some oral lesions. We see the multiple cysts in the jaw, and these are odontogenic keratocysts like we were talking about. They can cause scalloping around the roots of the teeth, and they can become quite large. Some skeletal anomalies that occur in this condition are bifurcation of their ribs, shorter metacarpals, spina bifida, kyphoscoliosis, which is kyphosis, also known as hunchbacked, and then various neoplasms might occur: brain tumor, calcified ovarian fibromas, and mesenteric cysts. Mesentery is what kind of holds our inner organs together, so we can develop cysts in those regions. Osteogenic imperfecta. 70% of these cases are sporadic, so it's a recessive trait, or it suggests that it could be a recessive trait, and only 30% show a dominant. So 70% of them exhibit this recessive inheritance, and only 30 are dominant. Mutations occur that affect the collagen, which leads to abnormally formed bones that can fracture easily. In mild cases, they may show a blue sclera, and the sclera is the white part of your eye that's normally, pretty white, and it looks blue. It's a really interesting look. Congenital forms result in multiple fractures in newborns at birth, just from going through the birth canal. These babies are born with many fractured bones, and infants can experience fractures just by being moved, just by rolling them over or holding them or lifting them. You can cause fractures. Some oral manifestations that we can see with osteogenesis imperfecta is dentinogenesis imperfecta. 80% of the primary teeth would be affected and 35% of permanent, and it affects the crowns and the roots as well as the pulp. The pulp chambers are smaller than normal, and the teeth will have kind of an opalescent appearance or translucent that kind of darkens as they age. And because our dentin is not formed properly, the enamel is lost because the enamel lays down on top of the dentin, and if the dentin is weak, the enamel can't adhere and be strong. Torus mandibularis can be unilateral or bilateral, as you guys know. Occurrence before the age of 15 is extremely rare. We typically see this after puberty. And in these patients, positioning of x-rays may be difficult. And then we can also have it in the palate. As you guys know, it has a variable expression, and it's almost 100% penetrance. We see it more in women, 2 to 1. And we also see it more often in Native Americans. And typically this becomes apparent around the time of puberty as well. Exostosis is like tori, only it appears on the outer portion of that alveolar ridge on the buccal aspect of the teeth. It can be single, multiple, unilateral, bilateral. It's generally symptomless. Typically, we don't see it, or patients don't even maybe know it unless they traumatize it. This can make anesthesia challenging. If you were trying to give a PSA on this person, you can see how you'd have to go way back over and around that exostosis that's sticking out by those molars. Isolated cleft palate and cleft lip. They can be, you can have cleft lip alone, or you can have it along with cleft palate. There is an autosomal dominant trait. It occurs in about 1 in every 800 infants, and it is multifactorial in origin. Like I said, cleft lip can occur with cleft palate. Congenital lip pits are the most common syndrome that we see along with this. The pits in the corners of the mouth are rarely unilateral. We usually see them on both sides. And clefting is bilateral in about 80% of the patients. Hereditary hemorrhagic telangiectasia is, if you think hemorrhage, that's bleeding. In this case, if you can look at their lips, you can see all those little red petechiae or red dots. So what's happening here is we've got a dilation of all of the little capillaries there, and those lesions in the mucosa nasal cavity can lead to bleeding, epistaxis. So these patients have a risk of gingival hemorrhage. So we would definitely want to be aware of this and take special precautions with this patient. Multiple mucosal neuroma syndrome is also called MEN2B syndrome. It's characterized by tall patients. They typically have really thick, large lips, everted upper eyelids, so it's almost like their eyelids are turned inside out. We'll see some mucosal neuromas on the lip, tongue, maybe on that buccal mucosa and eyelids. And this is associated with medullary carcinoma of the thyroid. We see this in more than 75% of these patients, and 20% of those patients die due to a metastasis in that area. We can see cutaneous pigmentation, so pigments on their skin like little nevi, and sometimes skeletal abnormalities as well. Early diagnosis is imperative with this condition. This patient has little neuromas on the tip of the tongue as well as the upper lip. Those little knots that you see, and that's nerve tissue. Pheochromocytoma generally develops around adrenal glands. It's often bilateral, can be responsible for night sweats, high blood pressure, and diarrhea episodes. It can induce increased urinary levels of epinephrine, which is basically adrenaline, and other substances. So early diagnosis in this is also imperative due to the high malignancy potential of that thyroid carcinoma. Neurofibromatosis of von Recklinghausen. This patient, some of them look very scary. They get multiple neurofibromas of the maxillary palate. If you look at this palate, you can see the bumps, the large bumps. Those are the neurofibromas. We also, on their skin, will see what they call café au lait pigmentation. Café au lait means coffee with cream. So basically, these are light brown macules that we see on their face, maybe their lips and their skin. This can be aggravated with puberty. Many times we'll see a mental disability with these patients, as well as multiple skeletal problems, and can have a malignant transformation in 3 to 15%. So not a high chance for cancer, but it has been seen in up to 15% of the patients. And that picture on your left is pointing towards some café au lait spots. They can be found all over the body. It doesn't just have to be on the face or lips. We can see it on their trunk, arms, anywhere. And this person is a very severe case of this condition. Don't confuse cafe au lait of neurofibromatosis of von Recklinghausen with Peutz-Jeghers syndrome. We're going to see those melanotic macules in this patient too. Typically this one you're going to see around the lips, nose, mouth, eyes, in the facial region. And in this patient, remember Gardner syndrome developed intestinal polyps that become cancerous by the age of 30. In Peutz-Jeghers, these gastrointestinal polyps or polyposis are called hamartomas, and they are they're not malignant, so these typically are not a cancer problem. White sponge nevus is a familial white folded mucosal dysplasia. I actually have a graduate from this program that she had this condition, and she has 3 girls, and all 3 of her girls have it. It is a dominant condition. It has complete penetration, and it's characterized by a white corrugated soft folding of the buccal mucosa. So it looks like a severe case of hyperkeratosis, because there's a thick layer of keratin that desquamates, leaving a raw mucosal surface in some cases. And in white sponge nevus, the buccal mucosa is always affected, and the free gingiva is never affected. It is always spared. So we definitely see it on the buccal mucosa, and this is what it looks like. It just looks like they've chewed the living daylights out of their cheek. But it's like this a lot, and it's not painful, but it's irritating. And the student that I had that had this was super self-conscious about it. Again, we've already touched on amelogenesis imperfecta. It is an inherited condition affecting the enamel, and dentinogenesis imperfecta that we talked about affects the dentin. The hard thing with those is in amelogenesis imperfecta, the enamel can be affected to different degrees, and it could be just pitted. It can be, they call it snow capped, which I've got a picture in here, different degrees of effect. But with dentinogenesis, the dentin doesn't form properly, so the enamel doesn't lay down and adhere to the dentin like it could or should. So in that case, with dentinogenesis imperfecta, you're going to have some effects to the enamel as well. There's hypoplastic amelogenesis imperfecta, which is where the enamel just doesn't develop to a normal thickness. There's the type 2, which is hypocalcified, which it's the normal thickness, but it's poorly calcified. There's hypomaturation, which is where the enamel is just softer than normal, and it on x-ray looks like a snow capped appearance on these teeth. And then there's hypoplastic and hypomaturation, which is associated with toroodontic teeth. And remember, toroodonts I gave the comparison of my dad having really short legs. So toroodont has a really long pulp chamber and then really short little stubby roots. Radiographically, the enamel has a radiodensity similar to dentin. And like I said, those single-rooted teeth have large pulp chambers. Here's an image that's showing you dentinogenesis imperfecta now. So this is a hereditary opalescent dentin. It kind of looks yellow too because you're seeing a lot of the dentin through. On the anterior teeth, you'll see that bluish hue, but on the posterior teeth, you see they're kind of amber colored or yellow. There's multiple types that are associated with osteogenesis imperfecta. We don't see pulp chambers when we take these radiographs, and the roots are short and thin and often associated with periapical radiolucencies. Here is an x-ray. You can see how odd the teeth look. You don't see pulp chambers. I'm looking to see if I see any periapical lesions. I can't really tell on those anterior teeth, but those are the things we'd be looking for. Dentin dysplasia is autosomal dominant, and there's a couple different types. Type 1 is radicular, and radicular means root. So if I have type 1, my teeth have normal looking crowns, but they have abnormal roots, and those teeth are going to be exfoliated prematurely. And I might see multiple, if you look at the root tips of these, you can kind of see periapical radiolucencies beginning around some of them. If I have type 2, which is coronal, my primary teeth are translucent with an amber color. Adult teeth are going to appear normal, but it shows an obliteration or partial lack of crown pulp of the pulp chambers, as well as small little root canals. And you can see it more in the upper teeth than you can those molars on the lower. Permanent teeth may or may not have pulp stones, which we talked about pulp stones in histology and embryology. And pulp stones are found either free or kind of floating or attached to the side of the pulp chamber, and those would be radiopaque. Hypohydrotic ectodermal dysplasia. Hypo means low, so hypohydrotic, in this condition, we see hypodontia, which is fewer teeth than normal. And you can see that they look like kind of like vampire fangs. They're kind of misshapen as well. Hypotrichosis is these patients have a decrease in hair formation. And hydrosis is a decreased ability to sweat. They have a lack of sweat glands. These patients have a difficult time living in a really warm climate because they don't have the sweat glands that can cool our bodies. So many of these patients have to live in kind of a more mild area so that they don't overheat. Hypophosphatasia is a decrease in your alkaline phosphatase in our blood. And we've talked about how important phosphates are for remineralization of teeth and bone. So the effects from this condition, hypo meaning low phosphatase, affects the formation of our bone and cementum. Teeth do not have cementum. Primary teeth will exfoliate prematurely. So many times the teeth are exfoliating without any sign of periodontal or gingival disease. It's due to the lack of phosphate and how that affects bone and cementum formation. We talked about vitamin D in nutrition, and you remember that it's associated with rickets in kiddos, osteomalacia in adults. So if we have hypophosphatemic vitamin D resistant rickets, again, that makes me think there's going to be a bone or lack of, because both of those, vitamin D and phosphate, is important in bone formation. So it's an X-linked dominant trait. So it would show low serum levels of phosphorus due to low absorption of the inorganic phosphate that's in our renal tubes. Rickets or osteomalacia are associated with this. Large pulp chambers and long pulp horns. Dentin has cracks, which lead to pulpal infection. Periapical abscesses can also result from this, and gingival abscesses. So gingival abscesses, you're not going to see radiographically. Those are soft tissue. You would see those by looking in the mouth. So we could see those, and possibly lymphadentitis, which is inflammation of the lymph glands. Pegged or absent maxillary lateral incisors. We know this runs in families. It is a dominant trait, but it has variable expression. So lateral incisors can be small, they could be peg-shaped, or they can be completely missing. So those are the different variants that you can see in the expression of this trait. Typically, they're conical shaped. The prevalence is 1 to 3% in the white population, 7% in Asian population. And interesting, premolars oftentimes are lacking in people that have this condition. In up to 20% of people that have peg laterals will also be lacking premolars. Here's our toradont with the short legs and long body. It's just a large pyramid-shaped molar with large pulp chambers. It's genetically heterogeneous condition, and it has dominant as well as recessive inheritance patterns. The furcation of the tooth is displaced apically, so you can see that it's, where the furcation is very low on the tooth, and they look like they have little short legs and a really long body. And that was associated with, I believe, that amelogenesis imperfecta, the type 4 that we were talking about. All right, so that covers chapter 6. I have put out online the, what do I want to say? Jeopardies. And I've also got the review out there. Hopefully you guys will have that. I am adding a couple more things to, I believe I have one more Jeopardy to put out there for you guys. I'm tweaking it a little bit, as well as the Jeopardies and the slides. I'm sorry, the review slides. I already said that about the Jeopardies, but the review slides will be out there. I'm going to be working on that this morning. And I will go ahead now that we're done with class, and I will publish those, and you guys can spend the rest of class time that we would be together looking over those things. So does anybody have anything that they would like to talk about before we end the meeting and just go to looking at things online? Studying the end of chapter questions, I think